as I say, the physical effects of pregnancy and childbirth. And I think my main passion for this morning is that it isn't scary. We're not talking about like, oh goodness, look at all these awful things that are going to happen to you. For me, as a woman, I think it's really important in life that we are told what's going on, how we can help that, what we should be doing to essentially anticipate for changes and be informed. Because I always say in most of the talks that I give, no one is angry because I have over-informed them. Women are angry because they were under-informed, whether that be through antenatal education that they feel didn't give them the real part of the picture, whether that be friends that they feel just didn't tell them what was going on. So hopefully I'm here today to just go through so you kind of know a little bit of what to expect, but most importantly, what you can be doing, because if we're empowered to understand, then I think that takes away a lot of the fear that can be there. And I totally understand all of those emotions. So a little bit about me. Yes, my title is a pelvic health physiotherapist, and you're going to meet a few of those today. We are physiotherapists, so we've done a normal physio degree. I think sometimes people don't necessarily know how we've got to our jobs because they can seem a bit more on the medical side at times rather than what you might associate as a physiotherapist. But through the kind of last 12 years, I've done a variety of positions, but the majority of my career has been in pelvic health in London in different NHS trusts, and then I moved into private practice. I now just work for myself, mainly because I have 2 young kids, and in a pandemic that is just what essentially started to work for the best. I've also recently decided to create something called All About Mum, which is starting off as cards, which are basically these cards that you can buy for a friend or buy for yourself, and you can pop them in your hospital bag, which give you the top tips that I really believe women should be given. So when you just have your baby, and I actually had a lady message me last night being like, I've just had a baby and I don't know what I'm doing, can you give me some top tips? So that's sort of what I vision that being part of, and I really just want to break down barriers, which is why I'm so delighted to be here with you today. So today's presentation, essentially I'm going to give you a quick tour of pregnancy, hormones, your pelvic floor, pelvic girdle pain, which some of you may experience, diastasis recti, which can be quite a buzz topic. It is a buzz topic at the minute, I would say. Postnatal, we're then going to think about what to expect, signs and symptoms you might experience, and think about returning exercise, and then how can a pelvic health physiotherapist like myself help you if any of the signs and symptoms that we talk about might be present, and kind of like how can you find one as well, because that's often a big part of the barrier, and for some of us a very frustrating part when sometimes the system doesn't quite work. I want to apologise for the blurriness of this picture, but I'm going to talk you through it. It's just all that I could find at the moment. So hormones, what is the deal? I think any pregnant lady is aware that she has hormones more than ever in her system. We can sometimes find ourselves more emotional or feeling things that physically that we weren't necessarily expecting. And I just want to give you very, very basic. So this, I'm hoping you can be able to see this little green, or my cursor, hopefully there's normally a little green spot, but we'll go with cursor. This is like a normal monthly cycle in our menstrual cycle as women. So the red is the estrogen, the more navy here is the progesterone. So you may well have seen this before, but you have this estrogen that comes obviously up just before ovulation. You then have a drop in a little curve, like a little roller coaster. The progesterone lies low, and then you have a bigger curve, and then it drops just before our period. In pregnancy, looks a little bit different. So the progesterone being the darker blue again, and then you have this coming, this really steady incline through all of the trimesters as it peaks at birth, and then this sudden drop postpartum. Same with the estrogen again. So, it gradually increases, and then you have these big drop again. So very different to what we'll have experienced in our life before pregnancy, where we're kind of more used to this ebb and flow. This is much more, we're dealing with much higher levels of these hormones. Estrogen, essentially, I mean, it's a wonderful hormone, and as women are very thankful for it. But in the system, our system, it can be a bit of a sensitizer. And when we come on to pelvic girdle pain, we're now understanding potentially that that's part of the picture when it comes to the pain in our experience. Progesterone, I mean, I think we're always quite aware of what progesterone can make us feel just before our period. So that can obviously be very true within our in pregnancy as well. Relaxin, I want to just touch on this hormone because I think it's had a lot of press and a lot of airtime, and though it is a relevant hormone in pregnancy and the levels do increase, the blame that it has got in the past for things like pelvic girdle pain are now not being proven anymore. We are disproving the kind of theory that relaxing is causing us pain. Yes, it does create, it makes things more stretchy, and that is present more within our system in pregnancy for good reasons, but the blame that it gets for negative things, we're kind of sort of disproving from a kind of musculoskeletal point of view. So I just wanted to touch on that there, in case you've been told that relaxing is the reason for your problems, which the reason I want to disprove that is because actually if we're just told, well, it's just your hormones, no one can do anything for you, that leaves you in a place where you're stuck with symptoms, when actually as physiotherapists, we know that you can be helped. So that's why it's important that we say, yes, there's hormonal changes going on, but the symptoms that we experience should not always be blamed truly on hormones, because there's not much we can do about those changing hormones, but there are other things that we can do to help you. So the other thing, obviously, we can always find ourselves a little bit more emotional. Having gone through it twice, I can definitely agree. I was a bit more of an emotional person. I do think motherhood's made me more emotional in general, though, and I don't think I can blame that on hormones anymore. But yeah, you will feel different things potentially. Being open and honest about that, expecting that, and knowing that these things are going on in your body is really empowering, that you're not going crazy. But if you are, from a mental health perspective, struggling, please do flag that. And there are mental health midwives who support women throughout pregnancy. You may find yourself feeling more low. You might find yourself feeling more anxious. And we definitely don't talk enough about that. We hear a lot about the postpartum anxiety, postpartum depression. But women during pregnancy can also be impacted in that. Hormones can be part of that picture, but there will often be other factors as well. Flagging it early and to your midwife will often seek the right support. And often physical symptoms and our mental health do often have a really strong relationship. So that's why I think it's important that we just mention that there. So your pelvic floor. So, I mean, definitely, in my opinion, your most important muscle group, and I'm sure a number of other speakers here today may agree with me, but I'm a little bit biased. But let's just have a look, because I think the interesting thing about the pelvic floor is often pregnancy is the first time you have probably ever come across it potentially, or been told about it, or you may still think, well, I've been told, oh yeah, do your pelvic floor exercises, but I haven't got a clue where that is or what we're talking about. So this is a rather pretty picture of the pelvic floor. We're looking down into the pelvis here. So here at the front, you've got your pubic bone, which if we then look at the model as well, you've got your pubic bone here at the front of you. The triangle at the back is meant to be representing the coccyx, which is the very, very base of your spine. And then as you can see, it's almost like a diamond. The pelvic floor stretches around this whole area at the floor of the pelvis. So it literally tells us where it is, around the back passage and around the vaginal opening. And there is lots of little muscles, and as you can see, they've all got lovely little names here, which you don't need to worry about at all. Just as physiotherapists, we're interested in that because it tells us actually a lot about where they are and where they run to and from. But for you, we don't need to be knowing about the names. We just need to know that that is where our pelvic floor is. So it helps us to basically visualize and identify. The pelvic floor has 5 key, I call them jobs, 5 S's. Okay, so support, what we're meaning here is it supports your pelvic organs. So when in pregnancy, essentially supporting your baby as well. Sphincteric, so you have sphincters around your back passage and around your urethra, which essentially keep you continent, and your pelvic floor is part of that. Sexual, I think we'll all agree, an important one. They contribute to our sexual pleasure. Stability, so the pelvic floor works with other muscles around the pelvic and the spinal area to work on kind of spinal stability support, probably a better word. And then what we call sump pump. And what we mean by this is muscles obviously contract around blood vessels, and therefore when we contract our pelvic floor, it pumps blood and lymph around the pelvic area. So another important job. So what's going on as in pregnancy, and why are we therefore now maybe for the first time thinking about our pelvic floor? So what can impact our pelvic floor? So the weight of our baby, obviously in the first trimester, baby's very small, and you may be someone who's keeping track of what vegetable or fruit your baby is, and suddenly you're like, wow, it's the size of a pineapple. If you think about that increased size and that increased weight, that puts quite a lot of weight and stretch on the pelvic floor. So that's one thing that can have an impact on us. Some women, not all women, but some women experience that their bowels change, habits change in pregnancy, and they may go into more of a constipation picture or struggling to open their bowels. now, our bowels have a big impact on our pelvic floor, and constipation or straining continuously, or more in a chronic sort of picture where we're doing it for a long amount of time, which pregnancy in the scheme of things in a year is quite a lot of a year. If we're repeatedly straining to open our bowels, that can have an impact in weakening our pelvic floor as well. Our breathing. Now, why is our breathing important? We just breathe every day, right? We don't necessarily think about it. But if we go back to the model, your diaphragm is the muscle that sits above the pelvic floor, and they have this relationship. Okay, so as we breathe and our diaphragm descends, the pelvic floor does as well. And as we breathe out, it goes up in the pelvic floor. So they sort of move. It's sort of been described a bit like a piston, but this gentle movement together. Now, obviously, as you, I'm sure a number of you are noticing, as you become more pregnant, there is just less space within your tummy and your abdomen, and your diaphragm is often then not able to descend quite as much as it would, which is sometimes why we experience being a little bit more breathless, one of the contributing factors. I definitely remember trying to walk and run for a train mid-pregnancy and trying to do a voice note on WhatsApp, and the person definitely knew I was pregnant because I was puffing and panting, and I felt like I was actually quite a fit individual. But there are changes obviously going on within your system that contribute, and obviously the space within your tummy being one of them. So that can have a change on our pelvic floor. Now, tears, this is where we all kind of go, please stop talking, I don't want to know about this. The reason I think it's important for us just to touch on tears is because there is a high percentage of first-time mums that will have an element of tearing with a vaginal birth. Okay, I've sat in that seat, I felt terrified, I've asked all the questions, and I've gone on to deliver 2 babies vaginally. But I appreciate it's not easy to hear about, but we have to consider it. And I think this is more important because actually often postpartum, we're then not given the education of how would we look after a muscle that's potentially had a tear in. So why do these tears happen? Essentially, when a baby is delivered and it has to come through the vaginal opening, there is stretching of the muscle. It often does happen gradually, but sometimes tears will occur in the muscle, or sometimes an episiotomy, which is a small cut that is done to the muscle by the medical team. For a variety of reasons, if an instrumental delivery is needed, it can be recommended. And also if the baby's getting distressed, or the baby's struggling to be delivered, they may also suggest that. There is 4 grades of tear. The first being more of a graze, which so often for women who have a 1st degree tear, we wouldn't necessarily do stitches. Women may not need stitches. Anything from a 2nd degree onwards will generally have some stitches placed into it. A 3rd and 4th degree tear does involve the back passage, and the management of that is slightly different, and often within the NHS there's a lot of support for women who have 3rd and 4th degree tears. So I do appreciate it depends on your location. So anytime we have a tear in a muscle, and I often say let's just come away from the pelvic floor and think about another muscle in the body. Okay, we might experience, you may have had a muscle tear elsewhere in your body, or you may have heard of kind of footballers having hamstring tears and things like that. So tears are often, you know, we recover, we rehabilitate, but we have to recover and rehabilitate from these things. That doesn't necessarily just mean pelvic floor squeezes, and I'm going to talk about that a little bit later. Delivery, obviously, the pelvic floor stretches an awful lot to allow a baby to deliver, which it's designed to do. It's amazing that it does it, but it has an impact on it to some extent. And that recovery can be ongoing kind of within that 1st year. So that's why we need to think about recovery, how long that takes, so we have an expectation for ourselves. So yes, however we deliver, whether it be vaginal or cesarean, however we birth, we need to think about our scars. So vaginally, there can be some restriction in the muscle if there's a particularly tight scar. I mean, all scars are generally on the tighter side, but that can actually restrict the pelvic floor movement. So as physiotherapists, we may encourage you to massage it. We may also use that within our treatment if you were to see one of us. Cesarean scars, also really important to massage, and I know Maria has done lots, she's going to be talking later, there's lots, does lots of wonderful awareness for cesarean recovery. So massaging scars is really important, and we can share some videos potentially with you as well. I'm aware that time is not necessarily on my side today, so I'm not going to go into all the strategies, but we can absolutely share more content with you at some point. So most importantly, how do we do these pelvic floor exercises? We are told to do them, but what does that really mean? This is just another image where obviously we're looking from the side of you. So you can see it's basically like this little hammock that sits underneath. So come round our bowel, around the vaginal opening and your bladder. So what is supported by research, and most of us physiotherapists will start you on a cue, is to think about holding wind. So think about it coming from your back passage. So you may have done yoga, you may have done Pilates and been told lots of different cues. I'd ask you probably just to think to start again and think about coming from your back passage and think about holding wind, visualizing it almost coming to the pubic bone. Sometimes we'll be taught to sort of think about lifting up towards our head. I prefer more of a forwards upwards movement lift rather than kind of a direct up towards your head, because the muscle fibers run forwards. Often I find for women when I'm examining them, that gets the best activation. But we don't all fit into research, okay? We are all individuals. So if holding wind doesn't work for you, maybe think about a zip from your back passage to your front passage. Maybe think about holding in a wee. Use another cue. I know there's lots of things about stacking up spaghetti and lifting marbles and lifting diamonds. What works for you is the most important. But if you haven't been doing these, start with hold wind and build from there. You'll often hear about these two separate types, fast and slow or short and long. It's not about speed. Essentially, when we're talking about fast or short ones, all we mean is that you fully contract, so you go fully hold wind and fully let go. And your let go is as important as your squeeze. So make sure you are feeling a full let go. And if you're struggling to feel that nice deep breath in between, can really help. I always compare it a bit to like an arm contraction. You wouldn't want to really do a bicep curl at the gym and just be doing this sort of range. You're not going to particularly have a lovely arm after that. You want to relax it. You want to get a nice full range of movement. The pelvic floor is no different. We want a strong but flexible pelvic floor, okay? Like all muscles in our body, we don't want something that's gripping and holding on. That's not incredibly effective. Your slow are then ones where we are basically focusing on a contraction, but with a hold. So you're holding that contraction, same contraction, but holding it there for 10 seconds whilst you breathe in and out. Now, I promise if you've not been doing these, 10 seconds does feel a little bit like eternity. Start with 5, build from there, but make sure you're just naturally breathing in and out. We're encouraged, and again, backed up by research, we should be aiming to do about 10 of each type 3 times a day, which sometimes you're like, Claire, I've got enough going on in my life without thinking about doing my pelvic floor as well. And I totally agree. But there is strong research to support that actually if we do our pelvic floor exercises in our early trimesters, it can reduce that risk of incontinence, which obviously I'm sure most of us want to avoid in the 3rd trimester and into postpartum. So there are so many benefits from doing our pelvic floor exercises in pregnancy. So I hope that maybe I've inspired you a little bit to be doing those if you haven't already. Don't panic, it is not too late. Lots of strategies to help you remember. There are apps available. You can set reminders on your phone, associate it with a daytime activity. Teeth brushing can be quite a good one. For most women, kind of lying or sitting is really lovely, but we also, if you can do it in standing, even better, because it's kind of the hardest position, but it challenges the muscle, and muscles need challenge at the end of the day. That's how we get them stronger. So let's briefly touch on pelvic girdle pain, because often it's not necessarily talked about, and it's often we don't necessarily know if there's any help for it. What is it? Okay, so pelvic girdle pain is pain essentially anywhere within the pelvic girdle, which is this whole structure. Okay, so either women will get it sort of around their pubic bone, others may experience it in the back. It can refer to other locations as well, but that's often where we might experience it. Someone may just get a few niggles around the area, a bit of exercise, a bit of stretching resolves it. Pelvic girdle pain is this more persisting over a number of weeks, pain impacting our quality of life, things like that. Often it will impact women's sleep, movement, emotions, and things like that. What causes it? Okay, so we've talked, okay, it's not relaxing, that is the driver for this. There could be a hormonal element that estrogen is a sensitizer, so we experience sort of pain more. There's been lots of links with potentially quality of our sleeps, especially in second pregnancies, we can then experience in that. Just our overall kind of reserves, how kind of worn down we are in our body. Sometimes, yes, related to kind of muscle tension in the area, especially tension within the pelvic floor, and that's why also letting go is really important. Often the drivers are individual, so that's why we need to treat you, assess you, and understand you as an individual to try and work out why you are experiencing this pain. What can be done to help? So early assessment and treatment and referral is very effective. So you may see a pelvic health physiotherapist. Some women will try and see an osteopath. Some may see a chiropractor. Essentially, you're looking for someone who is trained in treating women during pregnancy, especially pelvic girdle pain. It may involve some hands-on treatments. Often it's us looking at kind of beliefs and thoughts around pain as well. Looking at your movements and saying, right, exercise is good. Because often what happens when we experience pain, we anticipate pain or movement, we then get more afraid of moving, and that actually all plays into the experience of pain that we have. This pain is very real. It is absolutely present, and it's what we're experiencing. I've experienced pelvic girdle pain in both of my pregnancies, so I know how challenging it can be. But we've got to look at the whole of you. We've got to look at your physical self, your emotional self, the mental health impact of it as well. So when we're treating you as physiotherapists, we're looking at all of that. Most importantly, we're looking to keep you functional, looking at your daily life. How can we get a movement into it? How can we use movement actually to help release tension, to improve your pain, and to keep you functional for whatever that is in your life that you need and what you enjoy? Or if you come to me and say, Claire, I love Pilates, great, I'm going to work with you to try and help you stay doing Pilates, and if we need to modify a few things, we will. If you love more body weight movements, that is what we will do, because ultimately if it's something you enjoy, it is much easier to put it into our day than trying to give you something that you don't enjoy, because the motivation is always a lot lower. So let's just briefly talk about diastasis recti. So what do we need to know? So this is the natural separator. We've got six-pack muscles. We all have six-pack muscles, even if it doesn't feel like that anymore. And they gradually stretch apart as our baby grows, and the connective tissue essentially stretches as well, and we get this change within the abdominal wall. It's been shown to be present in 100% of women by 35 weeks of pregnancy. So the main message being there, it's not something for us to fear. It's a natural process and something that we need to happen so we can carry our baby. What you may see is this kind of bulging or doming down the middle. You might need to adapt sort of how you get in and out of bed or in and out of the bath. Don't panic if you see it. We just don't necessarily want to be repeatedly seeing it during pregnancy, but it's nothing to panic about if you do see it. And another important thing, as we've talked about before, bowels, not straining, because that puts an awful lot of pressure through, as I say, your pelvic floor, but also through your tummy as well. So your baby's here, they do these cute photo shoots potentially. I never did this, but I always think they look really cute. But what does this mean for you? Realistic expectations are so important. So let's have a little brief overview. So you've had your baby, you're in those early days. We expect we expect blood loss. Okay, so maternity pads are so important. I know some of my friends have been like, I've just got a period pad, and I'm like, no, maternity pads, you need the absorption, or even kind of a full-on like 10 a lady nappy. It's one of the best things I was told to get for my second delivery, and it really, really helped. Just with it's quite a high blood loss. We're all different. Some will bleed more than others depending on what's happened. But having, good effective pads and enough of them is really helpful. For most of us, we're going to have some pain and discomfort. So we will be given anti-inflammatories and painkillers, not being afraid to take them, absolutely safe, and be guided by your medical team. From a bladder perspective, what I want you to take away and know from this is, after you have given birth, obviously some of us may have a catheter, some of us may not. Either way, if the catheter's been removed, we want to do a wee within 6 hours. And again, after we've given birth, really we want to have done a wee within 6 hours. What we want to make sure is that your bladder doesn't overfill. And sometimes after birth, it doesn't quite remember 100% what it normally does. And it can sometimes hold too much urine. So if you're struggling to pass urine, you have lots of discomfort in that lower tummy, flag it to your midwife or your medical team. Bowels, obviously, if you've had a vaginal birth and you've had some stitches, it can be very natural to fear opening your bowels. I completely understand that. Couple of top tips: the minute you get an urge to go, don't put it off in the fear that it will get better, because often it can actually make it more challenging. Just go for the poo. Raise your feet up into a little stool, You can use a clean maternity pad to actually support the vulval area. So you would place it just here and support and splint as you're opening your bowels. You're not going to open your stitches, but it just gives a little bit of support and feedback. So vaginal birth top tips: if you're trying to sit on a chair and you're feeling quite uncomfortable in the vaginal vulval area, 2 rolled up towels on the seat, pop your legs on it so it raises the area that's uncomfortable. You can make what we call little padsicles, so like a clean sanitary pad, wet it with water, pop it in the freezer, and it'll become a little ice pack. So do let whoever you live with know before they start getting that freezer meal out, and there they find some sanitary pads that are frozen in the freezer. You'd take that sanitary pad out, you'd wrap it completely in like a flannel or a towel, one that you probably don't care about anymore, pop it over the vulval area for 5 to 10 minutes, and that can just have a lovely cooling effect. For your first wee, take a little cup of water, or there is this product called a peri bottle that you can take to basically just squeeze the area. Just the ammonia in the urine can kind of sting a little bit if you've got any grazes and cuts. So that can just be really helpful. From a cesarean point of view, have a cesarean birth, you know, you're going to want to keep rolling onto your side. So have something, or your hands supportive of the wound. If you're going to cough, sneeze and laugh, it won't open again, but it's just the pressure holding on the outside can really, really help. Early movement can actually be really helpful. Actually, lying in bed for too long doesn't always help, but getting up, little bits of movement, making it to the bathroom and back, little and often is often the best way. And again, asking for help wherever we can. So what symptoms may you experience after your delivery? So some women, the stats are generally urinary incontinence. We think at some point in women's life 1 in 3 women may experience that. From fecal incontinence is around 1 in 10. I think sometimes we think things are higher and some things are lower, but that's the general stats that we have. Incontinence essentially being where we lose control, and this can be of urine, feces or wind. And wind can actually be a big one where we're like, well, we can keep our urine and feces, but we're actually really struggling with our wind control, which understandably is embarrassing, and we can do something to help you. Urgency of needing a wee, so you need a wee, but it's just got to get there, super urgent, there's no kind of holding. You've noticed a significant increase in going for a wee. Now in pregnancy, and we often notice that is the case anyway, but if this is an ongoing thing postpartum that wasn't your life before pregnancy, even if it was before pregnancy, we want to help you, because you don't need to be kind of controlled by your bladder and being told to go really, really frequently. On average, 6 to 8 times a day is what we would label as normal. Though I kind of hate the word normal, because then I'm like, well, does that make me abnormal? No, it doesn't make you abnormal, but just that's our normal, sort of from a medical term, what we put that label as. A prolapse, I haven't got lots of time to go into lots about prolapse. I do share a lot about prolapse on social media, so if this is something you are worried about, do come and have a look. Essentially, prolapse is when one of our pelvic organs does drop from where it is, and this is for a number of reasons, but essentially the symptoms I want you to know to look out for are like a heaviness or a dragging sensation. Again, they can be quite common. It's definitely not the end of the road. Please don't Google prolapse. Get some support. Physiotherapy is the first line treatment in the UK, so you should be referred to a physiotherapist for support. I say should, it doesn't always happen. Diastasis recti, obviously I've mentioned what to look out for. That can obviously go on postpartum. We think around 1/3 of women may need help with diastasis postpartum. 2/3, there's just this natural recovery, no problem. Pelvic girdle pain, most of the time it ends at birth if women do experience it, but sometimes it will linger. Again, don't put up with it. There absolutely is help. And then pain with sexual intercourse can absolutely be present postpartum, and again the stats are quite high. And again, I flag this because sex should never have to be painful. Don't let someone say, well, you've just had a baby, what do you expect? I would say often women don't return to sex before 6 weeks, but what I would say is ongoingly impossible to have comfortable or have sex at all, penetrative sex I'm talking about, then please do flag that. That is not normal. It should not be something that's ongoing. There is absolutely help. So let's obviously think about moving on to exercise. So often you'll hear this 6-week window here, right? 6 weeks, potentially see a GP, though at the minute that's looking more like 8 weeks. And I'll talk a bit more about the GP check in a second. But I'm also aware, Suzanne, that I'm going over, but I'm nearly done. Moving so yes, you might see the GP. But the reason we talk about this 6 weeks is because it is essentially a soft tissue healing window, but it's not necessarily completely finished at 6 weeks. Okay, so that's why it's 6 weeks. It's not a magic number. We're not suddenly who we were pre-pregnancy. Yes, it's saying that any wounds we've had have done the bulk of the work of healing, but especially after cesarean, we know that that is still ongoing. Okay, so wounds are not opening or anything like that, but we are saying that your body is still recovering the scar, is still making some changes, and we need to respect that as we return to exercise. So movement in the early days, and the reason I want to talk about this, and when I mean early days, I mean first days and weeks after having your baby. You'll hear this whole stay in bed for a week, be on the sofa for a week. Ultimately, I think you have to do what's right for you. Your birth will be different. Ultimately, we don't want you literally only staying in bed because we don't want any blood clots in our legs or anything like that. We want you to be up and little bits of movement, okay? But I think the main message I want to get through, and women always say to me in clinic, is that some women go out for like half-hour walks at 1 week or 2 weeks, and they're like, I just wish someone had told me that actually that's potentially wasn't the best idea. Ultimately, you need to be led by your body, but often because we are still potentially taking painkillers and stuff, you may not quite get the same feedback loop as you would have done if you weren't. So start with small little walks around the corner. This whole like you can never walk too much, I don't personally agree with. I think you definitely can walk too much, and I definitely think I did walk too much. So it's about trying to steadily, incrementally build back up your lengths of walks. But getting outside is great for our mental health. Getting movement is great. You can do your pelvic floor exercises. You can do deep breathing exercises. You can do kind of upper back mobility exercises. You can move. Movement is okay. You're not going to be inactive with a small baby, but think about what activity looks like, rather than it having to be like, I've got to get out for a half-hour walk because I need to get my steps in. Just try and put that to bed for a few weeks. You will get back there, okay? We're encouraged to, after having a baby, think about over time returning to this 150 minutes of moderate intensity activity a week. I just think that as mothers, we need a realistic expectation of what does that look like. It doesn't always mean about half an hour workout like it used to. And as this kind of infographic shows, activity is the more focus that we're looking at rather than like exercise. Activity and being active is possible in so many spheres of parenthood. And it's just thinking about how actually in this new season of my life can I do that? Can I grab 10 minutes doing a little bit of Pilates, postnatal Pilates? Can I do that after 6 to 8 weeks? Does it feel good? Does it feel helpful for me? If it becomes a stress, it's not necessarily the right thing. Some of us will have childcare and maybe support, some of us won't. So what can we do with our baby and how does that look? Finding things in your local area. Returning to impact sports, so things like running or jumping or more heavy weightlifting. The current guidelines that we have are suggesting really earliest 12 weeks, and that's really if we've done quite extensive rehab between 6 to 12 weeks. It doesn't mean, okay, I waited 12 weeks and I'm just going to hit my old 5k route that I used to do. We need to think about our whole body when we return to impact exercise, not just our pelvic floor. We need to be thinking if we've got any symptoms, and when we do return to things like running, like a couch to 5k approach is generally better like a walk run program. So how can we get help? We are here to support you throughout pregnancy, throughout life, pregnancy, postpartum and onwards. From an NHS perspective, if you are pregnant, you can speak to your midwife or your GP. I'd say generally midwives will be your first route. They may know about the services in your hospital. Postpartum, obviously midwifery care often doesn't last for so many weeks, so often you may have to then access it via your GP. Depending on your GP and their knowledge of services, it may vary, and it will also vary on your area. Been put in the resources is the Squeezy app directory. You can pop in your local area and it will come up with both NHS and private physios in your area. And sometimes with the NHS we'll actually talk about referral route, because some places you can self-refer, some places you need GP referral. Sometimes you'll go to see like a gynecologist before you'll see a physio, and some you'll go directly. It totally depends on the NHS trust, and I'm sure all the physios here would be able to talk about different places that they work and how that works. There is obviously support privately, but that comes with a financial impact. But then also if you have insurance, lots of physios will accept that as well. There you go.